people, we have about 10 people who are at the live stream.
Oh,
so,
nice. Okay. Yeah.
Here. Ready? Okay, we're going to get started. Sort of.
Right, I know.
This is like...
Class.
I'm kidding. Okay, well, welcome to our fourth and final session of our Toolbox for Aging series. I'm Rebecca Kovac. I'm president of the Jewish Federation of Lane County, and this series was organized by our Social Services Committee and co-sponsored by Temple Beth Israel. This series is intended to provide useful information as you age and need to make important decisions. The first session covered legal issues, and next we learned about living options. Last week, Rabbi Ruhi explained some rituals surrounding life and death decisions, and tonight we have two topics. First, Kim Dunn will explain palliative care and hospice, and finally we will hear from the Chevra Kadisha about funeral planning and the rituals involved. All of the sessions will be available on YouTube, and the Jewish Federation's e-news will give the link for all of those sessions that if you've missed one, you can go back and review the recording. And the link will be in the e-news. Before we get started, I want to give a special shout out and thank you to Michael Griffel, who is our live streaming person. Thank you, Michael. He has done this for 4 sessions in a row. We're really grateful. Thank you, Michael. So Kim, who's with us tonight, is the hospice care consultant for Brighton Hospice. She has a degree in gerontology and a strong passion for helping people age gracefully. Kim started as a community relations director in memory care prior to coming to hospice. As a hospice care consultant, she helps to educate and navigate the benefits of hospice with families, physicians, and senior living communities. Her goal is to make sure that people utilize the wonderful benefit of hospice so that there's dignity when their time comes. We will have the first session and then have questions and answers, and then we'll move on to the second half of our session tonight. So, Kim, thank you.
Thank you. Good evening. We'll see what's happening here, sorry. Do we care about the slides? After you went through all of that. Sorry. Definitely don't have to re-announce myself, but my name is Kim. When I do this presentation, I want to leave space for questions so that you can ask as I go through the information. I am with Brighton Hospice, and just to give you a little information, in case you don't know, there are actually 6 hospice agencies that serve the Eugene, Springfield, and surrounding areas. And not to make light of it, but I mean, there's enough work for all of us, so. And I'm going to be speaking tonight on the behalf of the benefits of palliative and hospice, not from a Brighton perspective, okay? Because I believe everyone needs to have the information and the education, then you get to go out and make the choices. I would encourage you that if palliative or hospice were to come into your life realm, that you spend some time interviewing the different agencies, finding out what aligns with what your core beliefs are, what your desires are, because we're all a little different. Medicare sets the guidelines for the type of services we provide, but how we provide them, how much we provide, is each individual agency. An example, so Peace Health Sacred Heart Hospice. It's a Catholic entity, so if death with dignity or anything like that was something on your radar, they won't participate in that. So that wouldn't align, with your wishes. So other agencies, might explore those options with you. Hospice in no way can participate in it, but we can educate and guide you along and be there before and after. That's not the topic, though, but just wanted to let you know. Jump over here, hit this. So the word palliative is used in a large fashion. So palliative basically just means, I'm going to look at my notes here, it's symptom management is what it is. So you'll hear palliative used for palliative care, and you'll hear palliative used for hospice, because it's all about symptom management. Palliative care is for people who have a serious or chronic illness. So it could be somebody with cancer. You know, hospice is pretty, synonymous with cancer. Dementia, chronic heart failure, chronic obstructive pulmonary disease, and then neuromuscular diseases such as Parkinson's, ALS. So with palliative care, the simplest way to describe it is that it's comfort care, okay? But you can still, if you're seeking palliative treatment or services, you can still seek out curative treatment. So currently today, most of us, if we have an ache, a pain, something's going on with us, we want to go to the doctor because we're looking for a cure or an answer. Okay? On palliative, you can still do that because you're still seeking that. Where on hospice, you're looking for comfort. Curative could be anything, like the example says up there. It can be cardiac rehab, chemotherapy, even rehabilitation. So it could be in-home physical therapy, occupational therapy, or services in a skilled nursing facility. And that's all considered curative. Palliative care can start at the time of diagnosis. So as soon as someone is diagnosed with, a serious or chronic illness, they can tap into the palliative benefit. Questions about that part? All right. No, I gotta hit the button over here. All right. Palliative care services are typically provided by doctors, nurses. Generally here in the Eugene, Springfield area, it's done by nurse practitioners. Sometimes RNs, but most likely it's nurse practitioners, and also social workers are part of the palliative package. Palliative works hand in hand with the primary care physician. So if you have someone with a chronic illness, going to the doctor, as we all know, whether you have a chronic illness or not, is really challenging nowadays, especially in this area, right? You try and make an appointment, yeah, we'll see you in October, right? So unfortunately, things get too bad. We utilize our emergency department. Have you heard the horror stories, right? 4 hours is nice. That's but typically it's 8 to 10 hours sometimes waiting. And you leave there with, make an appointment with your PCP, right? Maybe a prescription for something. So with palliative, the nurse practitioner works in coordination with the primary care physician. So typically with palliative, the nurse goes out every, depending on the agency, every 4, sometimes 8 weeks. They go to wherever the patient lives, checks in, see how they're doing, checking on those symptoms. If there's any changes, the nurse practitioner can make recommendations, can write prescriptions. If maybe they notice that there's an infection going on, there's increased pain, a change of condition, and then coordinates that with the primary care physician. So not having to tap into going to the doctor, right, but your primary care physician knows what's going on for you. Palliative care can happen wherever a patient lives. So it could be at home, it could be in a senior living community, it can be in a long-term care community. We have patients in motels, again, it's wherever they call home. And again, the goal of palliative is to provide relief of symptoms and then the stress of a chronic illness, because sometimes there's just not a whole lot you can do, the physician can do, but having that service at home reduces stress, not only for the patient, but on the system as well. Any questions? Anyone familiar with palliative services? No? All right. So what does it cost, right? That's always the question, sometimes with our healthcare, what does it cost? 1 second. So palliative care is treated just like a doctor visit. So it's It's covered by Medicare, Medicaid, and most private insurances. It is subject to deductible and your out-of-pocket. So it can, depending on your insurance coverage, if you have it, can be quite expensive. It does cover some medical supplies and durable medical equipment, but most of the time it doesn't. So what happens is you have to tap into that portion of your insurance based on your policy. So it's not all-encompassing, like when I talk about hospice kind of covers everything. Palliative does not. Everything is individual. Medication, same thing. It just goes under your pharmacy benefit. So any kind of medications that you're requiring, same thing, co-pays, out-of-pocket. So palliative, there is a cost to the patient. Questions, anything? You're good? All right, so that is basically just a high-level overview of palliative. So anyone can utilize palliative services. It does require a physician's referral, okay, in order to utilize that. Currently, today, the palliative system here in Eugene and Lane County are very taxed, so trying to get on palliative services can be a lengthy wait sometimes. And so we're trying to get, obviously more nurse practitioners and more people, more healthcare providers involved. Brighton does not have a palliative program. We've entertained it, but we have a different program that we utilize that's not so taxing. All right, so hospice care. So when you hear the word hospice, what comes to mind? Right? Yeah. Dying, death, end of life. You're right. You're right. He's like, can't sugarcoat it. So hospice it's a word that triggers a lot of emotions for people, whether you are the patient or a loved one of someone who's being presented with the option of hospice. It is a concept of care, meaning, again, it's not for curative. It's when people are not wanting to seek out treatment for their condition that's going on, or there's no longer an option for treatment. You might have heard it, from people. I'm tired. I don't want to get poked again. I don't want to go to the doctor. I just want to go to sleep, not wake up. That's not our job. That's one of the myths of hospice. It's like we don't make you go to sleep in that sense. So, but the real focus of hospice is comfort and quality of life, okay, rather than cure and quantity. And that's a big one. I use that a lot when speaking with patients and patients' family. It's like, it truly, at this point in time, if we're talking about hospice, it's about the quality of life, not the quantity. So breaking that down even further, it's like quantity of life would be probably going to the doctor, trying to find out what's going on, an arsenal of medications, right? So if you're always at the doctor, you're taking a lot of medication, you're spending a lot of money, to take care of that, what's the quality of your life? But if your symptoms can be controlled, symptoms can be anything from pain, anxiety, infections, things like that. If it can be controlled, you can have a better quality of life. Hospice doesn't mean you're strapped to a hospital bed and you can never get up again. I encourage people, if you're on a salt-free diet, a sugar-free diet, forget about it. Eat whatever you want, right, at this point. If you want to go to the casino, you want to go out to eat, you want to go to the coast, go. Just let us know, that you're going somewhere, but go. No, there are no rules when it comes to hospice. Hospice is not just about the patient. It views the patient, the family, and any other loved one within the unit as that's the whole patient, because those individuals also make up the patient, right? A lot of times people will not choose to go on hospice because they don't want to disappoint their loved ones. Because their loved ones are like, oh, come on, Mom, you can, like, how about, let's just go to the oncologist one more time. Let's try one more round of chemo. And I've literally had situations where I'm in a hospital room talking to a family, and the patient's like, oh, I want that. I just want to go home. I want to be in my bed. The family's like, we are coming back to the, going to the doctor on Tuesday, we have an appointment, we're gonna have surgery. And it's really just, being truthful, it's disappointing, but I get it, you know. It's an emotional journey for everyone. There is an interdisciplinary team approach in hospice, which meets not only the physical needs of the patient, but the emotional, social, and spiritual. So it's all encompassing there. And I will maybe share that with you. Sorry. Try this again. Okay. So if you remember, on palliative, it included, you know, typically a nurse practitioner and a social worker, okay? So in hospice, this is the whole team, okay? So a patient who chooses to go on hospice has the choice to choose a hospice medical director, or they can stay with their own primary care physician. Pros and cons to that: a lot of times primary care physicians will opt out of continuing to be the primary care physician because they don't see the patient physically anymore. So it's just, you know, medical record updates. The pro of staying or going with the medical director of hospice is that if something were to happen at 3 o'clock in the morning, the medical director can write orders right then. We don't have to do it on call and wait for hours for someone to call us back and make that decision. But patient is always at choice there. Every patient has an RN case manager, so that's the individual that visits the patient and checks in regularly. Hospice aides, also referred to as CNAs, so they provide the personal cares. So that can be assisting with bathing, changing clothes, if there are adult briefs, making sure that they're, you know, changed and clean. And just, you know, some camaraderie as well. They're not there to clean the house and that kind of stuff. And sometimes CNAs will do a little picking up, that kind of stuff. But really the goal of the hospice aide is to allow, if a patient is at home, is to allow the spouse or the loved ones to step out of the role of being a caregiver and be the spouse, you know, be the daughter, be the son, not the one that's having to change dad's brief, you know. But again, there's 23 other hours in the day. But whatever services, you know, hospice can provide at that time, you know, the spouse can go take a shower, you know, I can go walk around the block, I can talk to my neighbor. So that's the goal there. It includes a social worker as well. The social worker is in place to help navigate. We don't know what we don't know. So if you've never been in this position before, there's a lot of questions, there's a lot of services that we may not know about. So the social worker's job is to tap in to see if there's some additional maybe in-home caregivers that you might be eligible for or have access to. They assist with funeral arrangements, things like that, anything that you might need, and even, you know, family dynamics, because they tend to show up during those emotional times, right? You know, so we help with that. The chaplains and the spiritual care coordinators, they are there to meet the patient where they want to be met. I just had my first time dealing with a daughter who was Buddhist. And I did not know about their belief system around death, and it was very interesting. I learned a lot, and we spent a lot of time making sure that hospice aligned with her Buddhist beliefs. And so as a team, what I do is I take that back and I share that with my team so that we're conscious of what her concerns are. Even though her mother wasn't Buddhist, it was, you know, we've got to also look at that unit as a whole, because we're providing services to mom, but the daughter is the one that's, you know, has more of the concerns and needs extra support, not just the medical support that mom needs. Bereavement, so bereavement stays even after the patient is deceased. So I can't speak for the other agencies, but Brighton, ours are typically about 13 months. It can go longer if families need it. It can also be shorter if that's what they also, you know, request. We provide different support groups that will continue on so they can attend those for years. Sometimes people just need that bereavement support. Volunteers are involved, so volunteers can be anything from pet therapy. Brighton has a adorable copper long-haired dachshund. His name is Walter. I don't know if anybody's seen Walter out and about, you know. He's adorable. He has his own little volunteer vest, and he's in a stroller. I'm not sure why he's in a stroller, but, you know, if I was a dog, don't know if I'd want to be in a stroller. So we have volunteers that play music. We have volunteers that, provide companionship, whatever is needed there. Patients can have access to a dietitian. Also additional therapy, so physical, occupational, or speech therapy. It's not long-term. It's not curative. It's sometimes people just, it's like, I think I would feel better if I could just get some strength back in my legs. So we would typically have a physical therapist come out, do an evaluation, and then provide exercises. And then the patient would, and the family would engage in the exercises to try and build the strength back up. The team also includes an on-call nurse, so it's 24-hour coverage. Again, I can't speak for the other agencies, but for Brighton, if you call us at 2 o'clock in the morning or 10 o'clock in the morning, you're always going to get a nurse. There's no answering service. So if something were to go sideways at 3 o'clock in the morning, any agency, you should be able to pick up the telephone, reach them, and they're going to assist with whatever's going on. It doesn't mean it always warrants a visit. Sometimes it's just some direction, what medications to give them, maybe elevating their head, something like that. Just, again, it's that comfort and care for the caregiver, because, again, if you've ever been in that experience, or situation, that it could be kind of scary. If somebody's, has shortness of breath, they can't catch their breath, or they're in a lot of pain, they're anxious. As the caregiver, there's a panic. The first thing you want to do is pick up the phone and call 911, right? So instead, the call goes to hospice. And then there's also complementary therapies. So those can be like aromatherapy, touch therapy. Again, there's a lot of documentation around touch therapy, especially with individuals who experience dementia towards their end of life. So being able to provide like hand massages, feet massages, things like that. And the aromatherapy it's good for all of us. Right? So, can I let that go? Okay, thank you. Sorry. Any questions about the team? Anything? All right. You guys are good. Yeah.
When you are talking with the patient's family or the patient, do you try to tailor that team to the needs that you see, or how does that work?
Sure. So the question was, when speaking with the patient and the patient's family, do we try and tailor the team to the needs of the family and the patient? Is that correct? Absolutely, yeah. So all of the team is available to every patient. If someone does not want spiritual care, they don't have to have spiritual care. If they don't want volunteer services, they don't have to have volunteer services. So the aides, so sometimes people are very private and they don't want anyone coming into their house. The spouse is like, I got this. I'm doing all my husband's showers and everything. And that's okay. It doesn't mean you lose the benefit. It just means that if and when it's needed, you can tap on, hospice's, door and say, all right, we need some help. So yes, we will tailor it, whatever. Does that answer your question for you in that sense? Okay, good, thank you. All right, so I'm on the wrong page. I flipped it wrong. All right, so what does hospice cost or cover? Anybody know how much hospice costs? Nothing, yeah. Finally, end of life and you get it for free, right? So, sorry, bad joke, but it's true. So with Medicare Part A, it covers hospice at 100%, okay? And that's for those who have Medicare. Is everyone familiar with Medicare Part A, what that is? That's the hospital side, okay? And then we've got Part B, C, D, F. But typically, most of our medical care is under A or it's B, and B is more your physicians, your lab work, things like that. So when a person chooses to go on hospice, we have to notify Medicare, and Medicare is like, okay, we're gonna flip I call them buckets, right? So it's gonna flip the bucket over. Hospice services get paid out of Part A with the intent that you're not gonna be going back to the doctor for any kind of curative treatment. But if you decide you want to leave hospice, you can. It's called revoking, and all we do is we tell Medicare that patient is revoking hospice. They flip the bucket back over, and now you have Part A and Part B available. And down the road, if you decide you want to come back on hospice, you can. There's no maximum benefit, no minimum. People, we've probably heard it before, you can go on and off a hospice, as much as is necessary. So with Medicare Part A paying for it 100%, no out-of-pocket, no deductible. Medicaid and veterans also pay for it 100%. Most commercial insurances, unfortunately, there's a deductible and the out-of-pocket, so whatever your benefits are there. So if you have private insurance and you're choosing hospice, you want to make sure that you're using a hospice that's within your network also, so you don't have any additional coverage or expenses. As far as what does it cover, so you get the nursing visits as well as all the interdisciplinary team, so there's no extra charge for the team. Hospice covers durable medical equipment, so if you were to need a hospital bed, wheelchair, walker, bedside commode, over-the-bed table, bed alarm for somebody with dementia, things like that, that is all covered under the umbrella of hospice. The medical supplies, so incontinence supplies, we call them chucks, so like the mattress covers, floating, we call them like foot floaters, so somebody who's if they are in bed, you get the pressure wounds, so any kind of medical supply to assist, again, with comfort is covered under hospice. And then also the hospice medications are covered. I do have to say hospice medications because there may be some medications that have been recommended to be stopped under hospice, but you as a patient have the choice to continue those medications. They're just not covered under hospice. They would just fall under your pharmacy benefits or be out of pocket. We have patients who are 97 years old and have lived in the Northwest their whole life, so they've lived off of vitamin D, and they don't want to give it up, and that is absolutely fine, But every patient who has an evaluation for hospice, there's a conversation about the medications, and what the medical director determines to be appropriate for the patient's condition and what are those medications that they feel they should stop because they're no longer providing any kind of relief. Example would be cholesterol medication, right? Cholesterol medication is provided so that we don't, develop cholesterol, which causes clots, which causes, a stroke. If you're on hospice, the chances of you, needing that cholesterol medication, in 20 years probably is not, So we would advise to stop that medication. We don't withhold food, we don't withhold water, we don't withhold oxygen. And again, if you want to stay on a particular medication, you have the right to do that, but you would be responsible for it financially. Questions about that? Can get a little tricky. Yes, ma'am.
So I'm very curious, and you're going to get this. I'm curious about that end of life point where I've seen some people get taken care with a lot of pain medication, morphine.
Right.
Is that a decision that's made between who?
So who makes a decision about the pain medication or morphine? That's a myth, really. Morphine helping a person leave is a myth. So morphine, most of us, we hear morphine, we think hospice, right? We think death. Morphine is a very old medication. The primary use of morphine is for breathing, because when the body is going through the transition, when it's starting to shut down, there's an anxiety that builds up. And so morphine is one of the most calming medications out there that helps with that breathing because the body's not getting the oxygen, right? So morphine is used there. Are we all familiar with the fight or flight mode? Okay. So if you think about someone who is transitioning, okay, and their body is fighting to take in air, right? And they are given morphine, okay, so the morphine relaxes their body. What happens? They can let go. So that's the myth, because people think that morphine is the one that has ended their life. Morphine has just allowed them to relax, to be able to give up the ghost, to relax and just, go peacefully. Does that make sense how that works? Yeah. And it's not just the patient or the families that are afraid of morphine. We have nurses that can, not in hospice, but, like nurses in care, communities, med passers, they're all afraid that, and like, I'm going to give that last dose. And it's like, well, you probably will be the person to give the last dose, but you help them to relax, to be able to go, okay? Because I'm going to assume in this room that probably all of us, if we think about our own death, we want to go as peaceful as possible, right? No one wants to go out in pain. We don't want to go out fighting. So if someone were to be able to give you something to relax you enough, we would all, want that, because sometimes we just, we can't give up when we're fighting. When the body's in the fight mode, it just can't go, and then it becomes, that's the hardest death, is when they don't let go. So, any questions or concerns about that? Does that make, okay, great question though. Sorry, I'm like, oh, where am I? Got on my tangent about morphine, so. So who's eligible for hospice? Okay. Anyone who's been diagnosed with a life-limiting condition and received a prognosis of 6 months or less. Now, we all know that quote, right? It's like on hospice, you only have 6 months or less to live. But the problem is, we don't know the rest of the quote. There's another part to the quote. So here's the true quote that Medicare has out there. If the patient's disease process were to run its natural course without any medical intervention, will the patient have less than 6 months to live? So you have to think about that. If I had a life-limiting condition and I did nothing, right, medically for the next 6 months, would I still be here? So that's what physicians are looking at is, okay, based on, your situation, if we don't do anything, I don't think you're going to be with us any longer. So that's when hospice would come in and take care of those symptoms. We're not trying to cure it, but just make sure that the pain, anxiety is reduced. So those life-limiting conditions can be a combination of things, sometimes aging, right? And with the aging comes, possibly strokes that have happened in the past. Obviously, cancer is one of them. Heart failure, neuromuscular diseases, things like that. Dementia is actually one of the top 5 diagnoses for hospice services. Not early stage or mid stage, it's typically the later stages because it's a disease with no cure. And unfortunately, it's only just gonna progress. So the sooner hospice can get on board for somebody with a dementia diagnosis, the better quality of life they're going to have. Because as that brain is, kind of shrinking and shutting down, all the other parts of their body are starting to shut down as well. So they're not able to swallow, they're having more falls, they're having more pain, more confusion, more anxiety. So being able to reduce all of that for them gives them that better quality of life. Another person who might be eligible for hospice care is if their goal of care is comfort versus curative. And I've said that a couple times. So again, that's the patient or the person's like, yeah, I'm done. I don't want to see another doctor. I don't want another poke. I just want to be comfortable. So that would be a good candidate for hospice, as long as they have a condition also, not just, I'm done. I have had that. I've had, community members who are in their 90s, like, I've had a really good life and I'm just tired. I don't want to do this anymore. What do you got? I'm like, nothing, it's like, I got some chocolate if you want that, but nothing I can do. I've had people ask about euthanasia. I'm like, well, I'm not a vet, so we don't do that either, so it's not the right term. And again, not to make light of it, but it's very interesting how everyone has a different perspective of death, right, and how they want to talk about it and deal with it. Another reason for being eligible for hospice is if there is no treatment, option, or the patient doesn't want to proceed with it. And then also if the patient or the family elect hospice. A lot of times, like I said earlier, families aren't emotionally ready, so it doesn't become an option because there's that conflict. Patient is always at choice unless they have diminished capacity to make that decision. Questions about eligibility? Where does it take place? And like with palliative, it can happen anywhere. So any place that a patient calls home. So home, obviously, a skilled nursing facility or long-term care, assisted living, memory care, a hospice house. So there's only one hospice house here in the Lane County area, and that is Pete Moore Hospice House, and that is run by Cascade Hospice. It's a beautiful facility. If you've never been there, take a tour. It's out the very end of Coburg, kind of before you go to Coburg, right? You just passed Costco. If anyone is interested in the hospice house, you definitely want to give them a call and find out some more information. It has very limited access, and there's some rules around using the hospice house. Typically, it's for people who are imminent, so you have up to 5 days of coverage to use the house. If a patient were to live longer than the 5 days, it becomes an out-of-pocket expense, and it's about $475 a day, and it's not covered by insurance. Yeah, and then they have one other aspect, which is called GIP, or general inpatient, and that's for patients whose pain is not able to be controlled, so they need to be in more of a hospital setting, but they can do that at the house, the hospital house. It's called continuous care, so it's like 24/7 care. There's also,
How is that different from a hospital?
it's not. Oh, so how is it different than a hospital? It's just, it's not clinical, right? So the house is set up like a beautiful house, very like a lodge type thing. But patients can also have GIP, or general inpatient services, in a hospital. Both McKinsey, Willamette, and Riverbend offer GIP. So basically, the patient is staying in the hospital, but hospice comes in and provides all the services. But they're having the 24/7 care of the hospital staff. So usually it's for people who, the biggest reason is that uncontrolled pain. I mean, there's not enough, oral medication that we can give them to make them comfortable. So they can get injections and that kind of stuff to make them more comfortable. And it does happen. How long do they stay in that situation? Sometimes if the pain is under control, it can be, hours, a day. Other times people, will end up just staying there until they pass. So, as far as the length of time, again, it all depends. Yeah, usually general inpatient is relatively short. It's not like months or anything like that. So it can be 7 to 10 days sometimes, yeah. No, absolutely, thank you. Questions about where it takes place? All right, jumping over to facts and myths of hospice, and I'll wrap it up here. So the facts, so focus is on care, comfort, and quality of life, not the quantity. It's patient-centered, so all the services come to the patient. It is support for the family. It's medical care to manage pain and symptoms, and you can choose your hospice provider, okay? So make sure, if you have the knowledge, interview. Just because you go to Peace Health Riverbend doesn't mean you have to have Sacred Heart Hospice, even though if they come in your room and knock on your door. You don't have to choose them. You can make phone calls, talk to your friends. Maybe you've had a previous experience with a hospice agency. Absolutely, word of mouth is super important. Myths about hospice. Hospice does not mean you're giving up. Can't tell you how many times I hear that. It's like, well, my family's going to think I'm giving up. It's like, well, what are you giving up? It's like, well, I don't want to go to the doctor. Okay, well, you're giving up going to the doctor, but it doesn't mean you're giving up on life. You just want that quality, right? You want to be able to go to the barbecues and, hang out with your family and not have to worry about doctor's appointments and not being comfortable. Myth is once you're on hospice, you can't go back. Said that earlier. You can go on and off of hospice as many times as you need. We've had people on hospice for years because they continue to qualify. Medicare does require that a patient be recertified. And that is up to our medical director to determine, yes, this patient should stay on hospice, or no, it's time for them to come off. And then typically what happens if a patient, we used to call it graduate. I personally don't like that word graduate because it means, in my mind, it means something different, like you've completed something, now you're going on to something else. I don't want to give people false hope, but sometimes, when you're on hospice, your symptoms are being controlled. You start feeling better. It's like, you know what, I think I do want to go back to the cardiologist and see if, maybe there's something else going on. And you can do that. So You can come off a hospice, seek medical treatment, and if you need it, come back on. I said this earlier, the myth, hospice does not withhold food, water, oxygen. If you know anything about the dying process, is the body does not want food and it does not want hydration. Think about if you've ever had a pet die. Okay, your pets, that's one of the first signs. They stop eating, they stop drinking, they go and they find a spot and they just stay there until, they're gone. A lot of time, our love language is food, right? We want everyone to eat. You got to eat. And the body is shutting down. It doesn't want it. And, well, what about tube feeding? We've got to get something in there. Tube feeding can be pretty cruel for someone who is in end of life because the body is going to resist the food, right? Even though it's going in, and what happens is they end up, vomiting. They can aspirate it, which then turns into pneumonia, and, it can be, pretty nasty in that sense. And another myth is it does not speed up death. So again, it goes back to the morphine, and we're not there to hasten death. We're just there to make it as peaceful as possible as soon as it, when it does come. So, and that, my friends, that's really it. There's information about Brighton Hospice on the back. If anyone ever wants to have a conversation about hospice or palliative, please, feel free to reach out. What I love about Brighton Hospice is that we are about education. If you choose us, great. If you don't, that's okay. At least you have the knowledge. Go out there. I spend a lot of my time talking with families about hospice and what it's not good for, but how it can be beneficial. And then there's sometimes like, this is not the right time, for hospice, and that's okay. I don't get anything for it. It's not like sometimes I feel like an ambulance chaser, but it's like, no, I just want people to have the benefit. I'll be in the grocery store and I see an older person that's really frail, and I'm like, oh, here's my badge. I'm kind of showing my badge. I'm like, hey, no. It's a wonderful benefit that at some point, hopefully all of us will utilize, so that we can be comfortable. So, all right, there you go. That was a long 20 minutes. So you are so welcome. So, sorry.
Great. Okay. Thanks, yeah. Okay, now we're going to hear from Chevra Kadisha, Libby, and Gary. And before you get started, I also want to just say thank you for this incredible mitzvah that you all do for Temple Beth Israel. I come from a community that does not have Chevra Kadisha, and when my dad passed away, I saw the services that weren't given that you all give to our community. So thank you so much. And the floor is yours.
Welcome, everyone. Thanks for coming. And special thanks to Leslie Griffel, Rebecca Kovac, and the Jewish Federation of Lane County for putting this wonderful series on. It's really a great idea, and I'm really glad that you're doing it and that we're doing it together. Libby and I will share off different parts. I'll start off with a piece, and then she'll take up a piece. But I want to say one thing. Libby was started with the Chevra Kadisha at the very beginning here in Eugene. So when Myron Kinberg asked for people to join him in doing this, Libby was there, and she's been there for the whole time. So she really knows this well, and I'm delighted that she's here with us today to talk about Chevra Kadisha. So I want to say that before I got started. So this session will focus on the role of Chevra Kadisha, or Jewish Burial Society. Hopefully, it'll give you a sense of what happens when death occurs, and it'll give a sense of the nature of the practice in our community to deal with death and mourning. Okay, that's the basic plan. And I think since we have such a small group tonight, people can feel free to ask questions. We'll have opportunities for questions and discussion. So, okay, now Libby's going to do a thing on the history.
Thanks, Gary. Gary asked me to give a brief history of our Chevra Kadisha, so I tried to edit down a longer workshop. So, our Chevra Kadisha was started by Rabbi Myron Kimberg of blessed memory about 40 years ago. Rabbi Myron put a notice in the TBI newsletter inviting anybody who might be interested in learning about Chevra Kadisha to come to a meeting at the TBI office. He organized a small class for us to learn about the customs and traditions, and he met with a couple of local funeral homes to explain our particular needs and wishes. Most of us in the class worked in healthcare at the time, and were also Shabbat morning regulars at TBI, so we were drawn both by our work experience and also by Rabbi Kimberg's four worlds approach to mitzvot: physical, mental, spiritual, and emotional. Since we seem to have some time, I'll say some of the first people at that class were Dr. Basil Friedman and Meir Yair and Yona Ash and some others, Diane Schechter, and others who have gone on to become funeral coordinators over the years. Our class studied biblical and Talmudic texts, Ashkenazic and Sephardic customs, and gathered samples of prayers and procedures, including for tahara, which means purification. It means washing the deceased person and dressing them in plain white cotton shrouds. Over time, we developed our own revised tahara manual to reflect the diversity and values of our community. Now we have volunteers who make our own simplified cotton shrouds, and we make sure that we have plain pine coffins at the funeral homes. We also revised the very helpful booklet, Treasure Each Day, which contains information about our Jewish customs dealing with death. Copies are in the social hall. We have one sitting there. Yes. So this is it, Treasure Each Day, a guide to Jewish rituals of death and mourning. And it's really excellent. It's very helpful. Whenever somebody calls Chevra Kadisha with a question, this is one of the things we bring with us for a home visit for them or mail to them. Let's see. As our congregation in Eugene grew, so did the number of people needing a Jewish burial. And Rabbi Kimberg was often called upon to officiate at funerals for TBI members and for others in the Jewish community who did not belong to a congregation. So beginning with that first Chevra Kadisha class, we eventually established a community with co-chairs and organized volunteers to help support families with some of their various needs when dealing with a death. In a few minutes, Gary will speak more about our organized system of funeral coordinators, which, as he described it, is at the heart of the services we offer. And since our Chevra Kadisha is all volunteers, I'd like to remind people, including those watching on YouTube, that it's a mitzvah to contribute tzedakah in memory of a loved one, and any donations that go to the Chevra Kadisha Fund help to pay for the material for the shrouds, printing the booklets, and some of the other needs when dealing with a death. Gary will speak more about that, I think. Oh, and the other thing, as far as tzedakah, which is very important, is that it's a mitzvah to help take care of indigent burials, and that's expensive too, so it's a good place to make a donation. In addition to the many devoted funeral coordinators and Chevra Kadisha volunteers over the years, I'd especially like to acknowledge the dedicated work of several people: Joan Bayless, Erwin Naparstok, Jesse Rappaport, Maram Epstein, Gary Tepfer, and Rabbis Myron Kimberg, Yitzhak Husbands-Hankin, Shoshana Spurgel, Maurice Harris, Boris Dolan, and Ruchi Sophia Motzkin-Rubenstein. Also, Rabbi Hanan Sills of blessed memory and Rabbi Jonathan Seidel have all helped as needed in our community with Chevra Kadisha and funeral needs, Shiva minions, whatever. Lastly, as part of our education about Chevra Kadisha, I attended several of the first National Chevra Kadisha conferences in the U.S., which were organized by David Zinner. More recently, David Zinner and Rabbi Stuart Kelman of Netivot, Shalom, and Berkeley established the Gamliel Institute and Kavod V'Nachum to further community education and share resources about Chevra Kadisha. For those interested in diving a little deeper into the subject, I'd like to recommend a couple of books which are available from Kavod V'Nachum. Hold on just a minute. This one's my favorite, Jewish Views of the Afterlife by Dr. Simcha Paul Raphael. And it's a very scholarly study of Jewish views of the afterlife from ancient times to modern psychology. Very interesting. He's involved also with Kavod V'Nachum, as is Rabbi Ariel Stone of Portland, Congregation Shir HaTikva. I think this year she's currently the chair of the Portland Chevra Kadisha. And this little book is the alphabet of death and dying as a Jew, and it's kind of reflections on some traditional sources. And here are some things from, the Gamliel Institute, Kavod HaEmet, Guide for the Bereaved, and Chesed Shel Emet, about preparing the body for burial. Another thing I meant to mention was that one of the things we did with our Chevra Kadisha is that initially we just used Rest Haven, but as those spaces set aside for Jewish burial were getting filled up, we made an agreement with the Eugene Masonic Cemetery down the street, and we're able to have another Jewish section. And lastly, in the last few years, after Musgrove's funeral home moved out to West Lawn Cemetery, Maram helped set up another large Jewish section there for burial, which will last our community a long time, I think. What else? I think that's about it for history. Yes, do you have any questions? I will say one more thing. Aishel here, Rosemarin, has been taking classes from Gamliel, and she can tell you more about it if she wishes.
Thank you, Libby. That's wonderful. So before I go on, I also brought a book. I thought about putting some of the images on slides, but I felt with a small group, as we saw last week, I just brought the book down And it's right here. I'll leave it, and people can come up and look at it afterwards. It's a wonderful series of paintings done in the 18th century for the Prague Synagogue. And it's a whole series of paintings on death practices, Chevra Kadisha. So take a look at it. It's open right here if you're interested. So I'm going to talk a little bit about the volunteer on-call funeral coordination system, which we have in Eugene, and I think it's really one of the many wonderful things we do. It's probably unique to a unique practice. I don't think it exists anywhere else that I know of, and I know that it's very helpful to people when death does happen. It was the idea of Rabbi Yitzhak Husbands Hankin that volunteers would assist with the practical details and mechanics of when death occurs. And it would free him so that the rabbi can spend more time with pastoral and ritual preparation. And just to give you a sense of what this is like, coordinating a funeral, just the coordination without any of the pastoral and ritual part can be more than all time consuming. So when a rabbi has a job to do, all kinds of demands on them, when a funeral comes along, this can be really over the top for them to put that all together. And that's where the idea came from for the volunteer on-call funeral coordinators. And here's sort of how things happen when someone dies. TBI office gets a call about a recent death. An on-call funeral coordinator is called, and that funeral coordinator contacts the family, offers condolences and assistance. And there's a lot of things that we do and go through, but I'll give you just a sense of some of the things and choices that the funeral coordinator helps the family with. It starts with choosing a funeral home. Sometimes it involves organizing transportation of a body to a funeral home. It involves choosing a cemetery plot, making decisions on whether to do burial or cremation, whether to have ritual tahara, the cleansing and dressing and body and before burial, or whether to do it or whether not to do it. Is it appropriate for a person considering their own beliefs? Next, the question of what kind of service you want. A funeral service, which can be held usually not in a synagogue, but usually it's held at a funeral home. But an alternative to that is, I think the most common is a graveside service. You can do both, actually, combination of funeral service and somewhere else, and then a graveside service or finish at the graveside. And another, for cremations and other reasons, you can have a service after a burial. Doesn't have to be right at the burial. You can do a memorial service generally afterwards. Those are some of the choices that are dealt with straight away. After a person is buried, after the burial takes place, the family would traditionally go home, or a person would go home, and the community would provide what's called the meal of condolence. It's a way that people come home from a funeral and they don't have to sit down and cook or do something like that or go to a restaurant. They can concentrate simply on what's on their mind, what's happening with them, and that meal is prepared by volunteers, the meal of condolence. And the Shiva, the first 7 days of the formal mourning process, starts the day of the burial. And it's traditional to do a service, usually at home, or it can be anywhere for that matter, but frequently it'll be at a person's home. Do a Shiva service. Frequently the rabbi will want to lead the first Shiva services, but we have, half a dozen lay leaders that in our community that do Shiva services, and we pass off to different ones. People do different ones, and it's traditional at a Shiva service when coming to a Shiva service, especially in someone's house, to offer food. That's kind of a tradition. Moral support and friendship, and the Jewish belief is that it's important to be surrounded by community, and community helps you through this process. And that's really what's so wonderful about Shiva. Some people choose to do one Shiva minyan. It can be done for a whole week, up to 7 different ones, and usually done in the evening, but not necessarily. It also could be an afternoon service. And it provides you with the opportunity, or the mourners with the opportunity, to say Kaddish. It's a short service. The focus is on saying Kaddish. And then afterwards, usually, there's an opportunity to remember the person that died. And that's a wonderful thing, because it not only gives the mourners a chance to talk about the person, and it also allows the community to get to know them in a way that they didn't know. I've been to wonderful Shiva services where and this happens so often, I think, oh gosh, I really would have liked to have known that person. That was really, really fascinating. And that's not uncommon. But generally, my experience is that it's therapeutic to do this process of talking and about a person that's died. And it's, I think, wonderful, once again, to be surrounded by a community of people that can support you in that. Then during the week of Shiva, meals can be organized. The Chevra Kadisha organizes people who voluntarily do meals. I know, Rebecca, you've been called on frequently, Leslie, Esther, and probably everyone here has done this. So it's a real mitzvah to be able to provide food. And once again, it just helps the family deal with what's most important to them, the business at hand, which is mourning, and not be involved in food. And also, relative to the subject of food, some people want to make Shiva into a kind of party. And it happens, and maybe that's the way some people want to do it, but traditionally it's not a party. It's traditionally the focus is simplicity, usually, and not catered food, but food that are brought by the people that are coming in and helping. So it's a donation more than it is something that one can buy. I also should say that the Chevra Kadisha forms a minyan when necessary. If for the funeral, it's traditional to always be buried with a minyan and be surrounded once again and supported by the community. And we're frequently called on to find 10 Jewish people that can form the minyan. And also for the Shiva services, we'll always make the necessary minyan so that we can do the service and you can say Kaddish. So I'd like to just I should ask some questions. If there's any questions on that have been raised and things I've mentioned just now. Esther.
How does one become a member of Chevra Kadisha if they would be interested?
Everyone can be a member. Oh, yeah. How do you become a member of the Chevra Kadisha? You contact a Chevra Kadisha member, and you say you want to be involved. And we have a list of people that do various things. We have a list of people that provide food. We have a list of people that do lead Shiva minions, and then a list of funeral coordinators. Some of those jobs require quite a bit of training. The funeral coordination requires quite a bit of training. But otherwise, it's something you can learn in process. Go along, let me know, let Libby know, let Maram. Oh, by the way, Maram Epstein's the head of our Chevra Kadisha. She's on leave right now, and that's why I'm standing here in her place. She'll be back soon, but Maram, or let the office know, say you're interested in Chevra Kadisha. Someone will contact you, find out what your interest is. So everyone can be a participant in Chevra Kadisha. Aisha. Okay, that's a great question. I didn't get into Shmira. How is Shmira handled? Shmira is a tradition of accompanying the body from death to burial. It arose, I think, in the days when it was never more than 24 hours from death to burial. And it was probably before there were funeral homes with refrigerators and things like that. So the Shmira, as it was performed over the years, is really hard to do for us because the funeral homes can't have people sitting overnight in their place. They need to have they have insurance regulations, and so it keeps us from sitting there and accompanying the body. Also, a body has to be refrigerated in the period of time before burial and after death. And so it's not in the olden days like you're sitting there next to the person. You'd be sitting in front of a refrigerator with a lot of other bodies sitting in there too. So I think the spirit of Shmira and doing it is very difficult to do here for us. I think in cities that have Jewish funeral homes, they have rabbinic students, they have people that do Shmira, they recite psalms, and it's possible. But we don't have those facilities here, and that's difficult. But what one can't, well, first of all, at least one funeral home in Eugene, Musgroves, was happy to cooperate to the extent that they can. So if they have a time, I know there was a death funeral I coordinated maybe a year ago, and the person really wanted to do Shmira. So they worked with her and allowed her to be there at the site where the body was next to the refrigerator, and she was able to commune and have that closeness that she wanted to have with the person that died. And the Musgroves turned out to be very, very cooperative with her. They originally said she could be there from 9 till 11, and it turns out she was able to be there most of the day. So it's possible if someone really wants to do it. It's possible to organize that. Day after day would be very difficult, I think, for the funeral home. And what I would say is really possible is to do a spiritual Shmira. One can do it from anywhere. You can do it in your home. You can offer prayers, and you can offer psalms, and you can offer thoughts, and the intention of Shmira can be done from anywhere. It's like Reiki, I guess. It can. So that's, I think, where we can handle and deal with Shmira at this point. Rebecca.
If you do not have a funeral plot, how do you all facilitate that once the death has occurred?
Good question. The question is, how do you get the funeral plot if it hasn't been bought before? Well, the funeral homes are very helpful in connecting you to cemeteries. And then also the funeral coordinators are good at that as well. So we will frequently go out to the cemetery with the family, accompany them, and look at plots and discuss the different places and the different costs. So that's something we're actively involved with. It's wonderful. I should say that in my experience, I've seen everything from a person where everything, when I got the call and I talked to someone, every single thing that's been arranged beforehand. This person, before they died, they bought their plot, they had every detail was in, and it was just amazing. That's one extreme. The other extreme is you get a call. I got a call once saying that this young woman was in the hospital and that her father had died. And I went there, and she was basically catatonic. She couldn't move, and she was paralyzed. And so he had to start from the beginning with every single step and just go right through it. So it depends on the person, what's been arranged, how much has been arranged. But, we're going to talk about the choices. Did you want to talk about the questionnaire? So, yeah, okay, that's something we forgot. Besides this wonderful Treasure Each Day brochure that's been put together, about the same time, this questionnaire of end-of-life choices it's out on the table there. Thanks, Barbara. And it's a great planning document. And it was put together with the idea that everyone should plan as much as they can. So it just goes through a whole list of things that need to be considered. So it's possible to get started early on getting these plans made. And as Joan Bayless likes to say, everyone should be here because it's going to happen to all of us. So everyone should be getting this news. I just found out recently that this has been updated within the last year, so its details should be fairly current. The synagogue, ideally, you'll do this document and put it on. The synagogue will keep it, or you'll just keep it and have it available, so we'll know what's happening. It was designed so that the Chevra Kadisha would know what people are planning, basically. So, yes, please.
Hi, so what if you know ahead of time, like I've been indigent most of my life. So, as I've spoken before to,
Libby?
like, I don't know if this is something I should speak about beforehand, like I'm going and I have no money.
Yeah.
So I don't know, how do you plan when you don't know what's gonna happen like that?
So the question is, go ahead. Yeah, the question is, how do you plan for death when you don't have you don't have the necessary things to make the plan? Is that accurate?
I have kids, but like my oldest is disabled, they're not gonna be able to do, like, I don't have anybody here to do, so, but I just sort of, I've wondered that ever since I was old enough to wonder about what has happened to me when I'm dead.
Yeah.
That's not changed in the last 40 years, that's
Can you answer that question, Libby? I'm not sure I know the answer, but it's definitely one that's, it's a good question worth finding out about. What do you know about that?
Sure. The question is, what do you do in the case of an indigent person who dies, who's Jewish, and somebody calls, the synagogue or whatever? Right. Right. But generally, that's why I brought up the tzedakah, because we do have some funds. We might not be able to pay everything, but we might be able to pay for some of it. I mean, funeral plots are now a lot more expensive than they used to be. But we can contribute towards some of the costs. And funeral homes also are sometimes, you can work with families And,
It's something we need to find more about.
yeah, I mean, it's changed.
So somebody who's on the live stream wanted to know where to get the form. Could you repeat
Oh,
that
this
question?
one? Mail it to me.
My personal wishes concerning end-of-life choices. Temple Beth Israel office has it. All of us funeral coordinators have it. So I think TBI office to start with, and they have it online, so I believe they can. It could be sent, emailed to you. Okay, Esther.
You might want to point out for people out there that there's constantly an opportunity to give money to specifically to Chevra Kadisha.
Right.
And that would go towards that Sataka fund to defray the cost for burial. So there's lots of opportunity to give.
That's right.
So I just wanted to end with, yeah, please, Isha.
Are Tahara services ever offered to the Meta at their home?
Yes.
Libby and I have done it.
Oh, yeah.
Oh, yeah. Can we do Tahara? Where can we do Tahara? Can you do it in the home?
Yes.
And the answer is yes, you can. I would say it can be difficult. So we do the best job we can because you don't, ideally, you have a funeral, a lift that lifts the body and dressing the body is difficult. Prep table, a bed that water can go off into. So we do the best job we can. If someone really wants to do it at home, it can be done there. It can be done pretty much anywhere, but it's usually a cut back version of the full tahara, because depending on the facility. Does that answer the question? Sure, go ahead.
And can Tahara be given to people who've chosen to be cremated? Can they have Tahara service?
Absolutely. In fact, people that are getting cremated sometimes want to have a simple coffin. So, yeah, yes, that's definitely a choice. Rebecca.
We have a lot of interfaith marriages in TBI, and I'm wondering about funeral arrangements when that happens. Is that spouse, who may be a member of the synagogue but is not Jewish, allowed to be buried with their Jewish
Yes.
Depends on which one.
husband or wife,
Yeah.
or partner, or whatever?
Rebecca's question is, can a non-Jewish spouse be buried with a Jewish spouse? So I think in Rest Haven, I don't believe.
All
Right. You cannot. The Jewish burial area is a kosher burial area. Pretty much. And so non-Jewish people are not buried in it, but there is an adjacent area right next to it, just outside the circle, which they do both non-Jewish members and also cremains. There's an area where you can bury cremains just outside of the Rest Haven, is my understanding, definitely allows for non-Jewish spouses to be buried in the Jewish section, and cremains can also be buried in there. Masonic. Did I say Masonic? Yeah. Masonic. And at Musgroves out in West Lawn, same. Yeah. So, yes. Sure.
Okay, thanks. Yeah, I would say Gary and I have both done Tahara at, I know I've done it at somebody's home for their non-Jewish spouse, in fact, who was, they do certain Jewish rituals at home, Shabbat and so on, never officially converted, but. So we just went to their house and did it there, and that was fine. And I think Rest Haven, it was established back in the 50s or something, or 60s maybe. Yeah, and that cemetery is almost entire, the Jewish section is almost entirely filled up. That's at Rest Haven. So in a sense, it's a little bit of a moot point about that. But Masonic definitely. Another thing I want to say is that just like with weddings, a rabbi is not halakhically, is not required by halakha for life cycle events like weddings and funerals. So there are times when some of us have, been willing to lead a simple funeral at the graveside, especially if it's somebody, I'm thinking about somebody who was indigent, somebody donated a partial lot because she was cremated, and some of us just did the service for her, and it was very meaningful. And from the beginning, our Chevra Kadisha has not just been about TBI members. I mean, from the first day, Rabbi Myron said, this is for the whole Jewish community, whether somebody is a member of a congregation or not. And at that time, TBI was the only place. This was long before, Ahavas Torah or Chabad or, there were some Chavras, but so basically it's for anybody who wants. And so there are some people on our Chevra Kadisha who are, able and willing to be flexible about non-Jewish partners together with a Jewish person, regardless of whether or not they belong to a synagogue. And as far as I know, that has not changed. So it's not just TBI policy. Like any rabbi has the right to decide whether or not they want to facilitate a service for anybody. I mean, some rabbis will do so for people who choose to be cremated, and others will not. But it's their personal choice, and they have a right to do that. But there are others among us who are willing to do that. So I don't know if that clarifies anything. Oh, I've also done Taharat at hospice, Peatmore Hospice, and it was lovely. The staff there became part of the whole Taharat process. It was very lovely.
Thanks, Libby. You just ended up with my planned finish.
What?
You just said it. Oh, you said it better than I did. I would have, but I would like to just wrap it up by saying that in this day and age, the biggest challenge, at least it is for me, is to coordinate the synagogue and the synagogue employees and staff and rabbi, this is for a funeral, the funeral home with their facility and their staff, the cemetery with their facility and staff, and with the family in mourning. It is almost impossible to get a burial to happen in less than 3 days, I would say. It can happen. It happened recently with just 2 days, but it's very unusual. And it's frequently 5 days before it happens. And it's a complicated game, and it's challenging, and it's wonderful, and it always works out. That's what is there's always a solution. So thank you, everybody. And if you have more questions, come on up. If you want to look at the pictures in the book, they're really amazing.
Thank you, Gary and Libby. That was excellent. And Kim, thank you. She stayed to hear your presentation, so she would have a better understanding of Jewish thought on burial and Chevra Kadisha. I just have one announcement to make, and this is for people who are live streaming as well. The Jewish Federation also has another event on June 7th at 5 o'clock Wednesday. The results of the Brandeis comprehensive community study that was done. Maybe some of you were called and participated in the questionnaire. The Brandeis professor who did the study with his staff is flying out to Portland and will be in Eugene. And so I hope as many of you who would like to come, you're all welcome. There'll be light refreshments. That's June 7th at 5 o'clock. and we will hear the results of the study for the first time ever in Lane County, and it will be at Temple Beth Israel in the social hall. So I hope to see a lot of you there, and with that, we will say good night. Thank you for coming. Yes. Yes. So the Chevra Kadisha committee will be doing another in-depth discussion about their role, what they do, answering questions next Wednesday at 7 o'clock here in the synagogue. So if you have more questions, be sure and attend that. And anything else, Leslie? Thank you. I want to give recognition to Leslie Griffel for putting all 4 sessions together. She did an incredible job. And thank you for coming tonight. Take care. Yeah. Yes, you're welcome. How did you help?